Well, in this case, we treated a rescued cat that had both legs partially amputated due to an electric shock. Based on a research paper, I designed a titanium prosthesis with rounded and porous structures distally. According to the paper, these structures would allow for skin and titanium integration and formation of seal. Initially, this approach worked well for around 8 months. However, the skin eventually started to shrink in that area, leading to recurring infections. Consequently, we had to remove the implants around the year of placement due to constant infection. And I was fortunate to attend a lecture by Professor Breitmark, whose family pioneered the method of titanium osseointegration, and I received some pointers. Firstly, titanium and skin do not form a proper seal. The skin must be anchored directly to the bone. Additionally, using screws to anchor the PSI plates in these cases is not ideal because they produce stress shielding. Stress shielding occurs when a bone or a portion of a bone experiences reduced mechanical loading or stress due to the presence of an implant, such as a metal prosthesis. This can lead to bone resorption or loss of bone density over time, weakening the bone and increasing the risk of implant loosening, implant failure, and bone fractures. The best devices for these procedures are those that go directly into the intramedullary canal, allowing bone and skin to bond directly. This approach allows the loads to be redistributed completely by the bone, avoiding stress shielding. In the jaw reconstruction field, I have worked on a fair share of cases, and I would like to share some of my views. Typically, the culprit is periodontal disease, essentially meaning bad teeth, where a large amount of bacteria and biofilm destroys the jawbone, eventually leading to fracture. One of the conundrums is precisely that even if the mandible is successfully reconstructed, untreated bad teeth can act as a time bomb. We have encountered cases where the prosthesis became infected and it had to be removed after only 1 year. We could observe a lack of dental hygiene that, while not always the main culprit, definitely contributed to the prosthesis infection. Therefore, it's crucial for owners to be fully committed to providing extreme dental care after these procedures. In my recent models, I'm trying to address some of these problems by providing enough space to avoid soft tissue tension. Additionally, I'm incorporating gaps in the prosthesis where muscle flaps like the sternocleidomastoid rotational flap could be anchored surrounding the prosthesis. This approach hopefully helps to avoid exposure in our future cases.